Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center, and I'm the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our guest this evening is a friend of mine and just one of the best cancer warriors there is, and that is Lisa Lacasse, president of the American Cancer Society Cancer Action Network. Welcome, Lisa.
Thanks for having me, Dick. I'm
Thank
very
you.
excited to be here.
Well, we're excited to have you here. And our topic tonight is the role of advocacy in cancer public policy. And there is no one who knows the topic better than President Lisa Lacasse. Before we talk about advocacy and public policy, though, Lisa, let's get to know you a little bit. Where are you from originally? Where'd you go to high school?
So I grew up in the great state of Maine, the capital of Maine, Augusta, Maine, which is where I was born. My extended family on both sides, my mom and my dad are both from there. Many, many relatives. And I'm actually coming to you from our summer house just outside of Augusta in Winthrop, Maine.
Awesome. And
And
how big was
I was at Coney, a strong Coney High School Ram. So that was my claim to fame when I was in high school. Yes.
and how many in your high school class?
So there were probably that's a really good question, 350.
Okay, so
Decent
pretty
size. Yeah.
pretty big. By
Yeah.
South Dakota standards, where I'm from, that's pretty big.
Yeah.
And then where did you go to college?
I went to the University of Vermont, the great state of Vermont, State University, one of the first land grant colleges in Burlington, Vermont. Loved my time there. Spent a year.
Beautiful.
Spent a year in Nice, France. Also, lovely place to live for a year.
So when you started college in Burlington,
Yep.
Vermont, what was your first major that you declared when you started college?
Political science. So it
And
is. I'm living my dream in so many ways. So yeah.
and
But I was
what the semester in Nice, what was that all about?
full year. And so I ended
Yeah.
up, I was a double major in English and political science. And then I minored in French and economics, go figure. So I kept myself quite busy. But my family is French Canadian, my heritage. And we, long time back to the 1400s, I've had a great aunt who did amazing genealogy, and we've been able to trace our family back to a very small town just outside of Paris. And so I was always really interested in the French language, although for those of you who maybe know a little bit about Canada, so the Quebecois is not quite Parisian French. And so I decided that I wanted to live abroad, and University of Vermont's program happened to be in the south of France in Nice. So
Okay.
it was not a hardship year, I can assure you.
So this is a French Canadian question.
Okay.
Have you eaten horse?
I have never eaten horse, not that I know of, at least. Was not a thing in Quebec.
Okay, I ate horse in Quebec. That's the only place I've ever had horse.
Yeah, if it was on the menu, I probably wouldn't have ordered it. I did eat a lot.
So who is your?
No, I was just
Sorry,
going
go
to say
ahead.
a good French Canadian tradition is baked beans. Baked in the oven all day on Saturday. You'd have this incredible smell in your house of molasses and brown bread. So I grew up eating that every Saturday night. So go figure.
Who is your favorite French political?
Oh my gosh, that is a hard question. And I don't know if I froze, Dick, but you did on my end. Now I can hear you again.
We're back.
Yes.
So,
apologies. Hopefully that's not my end. So, I didn't follow a lot of Canadian.
not Canadian, French, but you spent a year in France. You spent a year in France.
Oh, I thought you said Canada. Sorry, I was still focused on Canada.
French. I mean, there's a lot of them.
There are a lot of them, and I'm sort of thinking about who I would. I don't know how to answer that question.
Okay.
So
it's a stupid question.
Well, no, so someone who's a political science major who lived in France, you'd think I'd have a good answer to that. But when I was living in France that year, it was not very politically.
Gotcha. Because we borrowed a lot from the French in terms of the formation of our democracy. So,
100%.
I've heard you say this many times. Cancer is not a Republican versus Democratic issue. We don't have a pro-cancer lobby and an anti-cancer lobby. Um, what would you say? Why is there a need for the American Cancer Society to have its own special arm that deals with advocacy and public policy? What's
Yeah.
the reason
This
for
is
it?
one of my favorite questions to answer. And I think that one of the things that we've learned over a period of time is how critically impactful public policies can be to cancer patients and their families. And so, great public policies, like really good and insurance coverage, for example, reduces barriers for cancer patients. Bad insurance coverage, or is a barrier to equitable access to care. Tobacco control is another good example. Most of the progress that we've made in reducing a lot of cancer incidence and mortality has been the decline in the tobacco burden nationwide. And that's really happened because of public policy changes. So, one of the things that happened, the history of the American Cancer Society Cancer Action Network, is that back in the day, we were formed in 2001. So, we're a little over 23 years old now, I guess now, 24 next year. There was a recognition of how critically important elected officials were in the fight against cancer. And as Dick, you just mentioned, it does not matter what political party you represent, everyone is impacted by cancer. Everyone knows someone who has a cancer story, if they aren't their own, cancer story themselves. And so our work is all about engaging elected officials because they have so much power in reducing the cancer burden through their priorities.
Right. And so people think of American Cancer Society, if they think of research, they think of people in a laboratory with beakers and test tubes and kind of trying to design a new cancer drug. What
Very
is,
important.
yes, yes. I would say you probably do more work with a computer and with the telephone than with test tubes. Um, what are the critical pillars of the American Cancer Society, and how does American Cancer Society Cancer Action Network how do you do your job?
Yeah, so it's a great question. So we like to say we have a new, relatively new CEO, Dr. Karen Knutson. She's been here for about 3 years. And we talk about a tripartite strategy, which basically just means simply that there are three primary ways that we reduce the cancer burden. And we have a vision, we have a shared vision, which is to end cancer as we know it for everyone. So underlying all of our work is a through line of health equity. One of our most important jobs is to reduce cancer disparities. And those disparities sit in many places, many populations, rural populations included. And so there are three ways in which we work to reduce the cancer burden through mission execution. First, as Dick just mentioned, is through research. So we have a big research arm. Not only do we provide grants to institutions, so extramural work to scientists who are doing really important discovery related to cancer all across the country in all 50 states. We also, the second way in which we reduce the cancer burden is through direct patient services. So we have a patient support pillar led by a chief patient officer of the American Cancer Society. And that's everything from, all important education and awareness. We have a really robust website that many of you maybe are familiar with, cancer.org, that has been recently merged with ASCO, which is the Clinical Oncologists Association. And that allows for just incredibly rich education for patients, clinicians, so many different stakeholders. So that, and then also like lodging and transportation and things that cancer patients and their families really need if they are facing a cancer diagnosis. And then the third way that we reduce the cancer burden is through public policy advocacy. And so we use we're evidence-based, right? So our public policies are not, oh, we think this is a good idea, let's go lobby on it. It really we only take policy positions that have been proven through the science, that they actually impact cancer patients and their families and reduce barriers to care and to treatment, et cetera. And then with patient support, we often hear about problems that patients may have. So transportation is a really good example. And we know that there are states that have budgets that are passed every year. And we're finding that we're able to influence those appropriations, maybe providing transportation services, for example, working with Medicaid programs to make sure that transportation is a reimbursable expense for cancer patients who are on Medicaid. So we really look at the priorities of the American Cancer Society, which are the priorities of cancer patients and their families. And then we ask ourselves, what policies help us achieve those priorities? So if we want to reduce prostate cancer incidence and mortality, how do we help from a public policy standpoint pass a law that makes it easier, or makes prostate cancer detection and treatment better for patients?
What would you say are some of the real wins that you've had? Maybe identify a couple of national accomplishments that ACS CAN played a role in nationally, and then maybe also invite you to call out some wins that ACS CAN has had in states across the country, because you're obviously well, maybe it's not obvious. It is to me, but maybe not to everyone. You're not just in Washington, D.C. ACS CAN has a presence in all 50 states at the state capitals.
That we do. So I would say probably, politics our medium is politics, right? We're not political from a partisan standpoint, but our stakeholders are elected officials. And it is, needless to say, an interesting time in politics these days. And I've been doing this job for about 17 years. So, and it's always interesting every year. So at the national level, I would say probably one of the most important influences we have is related to appropriations. So funding for cancer research. And that is considered, we call that an evergreen campaign, because every single year we need to work with all members of Congress to talk about why the budget of the National Cancer Institute and the National Institutes of Health is so important to their constituents, and particularly their constituents that are facing cancer or maybe trying to prevent or early detect cancer. So from an appropriation standpoint, that's something that we have. ACS CAN has formed a really critical coalition called One Voice Against Cancer. It is over 50 cancer organizations. And like all of our advocacy work, the way in which we have the most impact is by ensuring that the patient voice and our patient stories get through. And so at the national level, I would say, particularly over the last few years, it's been a challenging environment to get things passed. But appropriations has been really important. I would say the other huge win that we've had is making healthcare insurance coverage more affordable. And so at the federal level, 2 years ago, and these tax credits are expiring, we were able to advocate to make health insurance coverage for those individuals who buy their own healthcare insurance. Their employer may not provide it. They buy healthcare insurance on a marketplace. We worked really hard to extend some tax credits, which makes that insurance more affordable. Thirdly, we're working lots of bills that we're working on, including clinical trial work. So again, it's really all about looking at different interventions and how important they are to our mission. And so that's at the federal level. At the state level, I did a little bit of my homework. And one of the things I really want to highlight is the incredible work that Iowa did this past legislative session on biomarker testing coverage. So what many of you, I'm sure, know, because I'm guessing that this is a pretty well-educated cancer audience. But with the introduction of precision medicine that has come onto the market, just incredible innovation that's reaching the market these days, that is really moving the needle on cancer treatment and therapies and therefore outcomes. For precision medicine, you actually need to have first a biomarker test or a series of biomarker testing. And what we had found over the last several years is that insurance coverage, even though in the guideline determined testing that should happen, it was not being covered. And you can well imagine the disparities that that was creating. So you had swaths of patients that were maybe getting the most innovative precision medicine care for their own cancer diagnosis. And then people, if they did not have biomarker testing, they were not therefore eligible to even know whether a different therapy would be much more effective for their cancer. And Iowa is now one of 20 states that was able to pass the law this past legislative session. 1.4 million people in Iowa that have been impacted. If they were to get a cancer diagnosis, they now insurance is required to cover that biomarker testing. And it's extremely hard work. It's a lot of shoe leather for our volunteers and teammates that do the lobbying in the state, but it really has incredible impact. And so biomarkers is one of our big accomplishments. We passed just a few years ago one of the best radon mitigation laws in the country in Iowa. So I really, so much of our impact comes at the state level, and all of you have a role to play in that.
Right. And the two examples you mentioned in Iowa, the Radon Act and the biomarker, cancer survivors, cancer patients, actually, two women with stage 4 cancer undergoing treatment, really over the years led the charge here in Iowa for both of those bills. And I'd go so far as to say we probably would not have gotten those bills passed if it weren't for individuals with cancer who are up there telling their story and the impact of radon in causing lung cancer, and also the role that biomarker testing had for, in the case of the two women that led the charge, biomarker testing showing mutations in their lung cancer cells for which there was a targeted therapy. I don't think we would have gotten those bills across the finish line, certainly not as quickly as we did without the work of those volunteers.
Yeah. And so you're identifying our most critical success factor in the work that we do, which is finding patients or family members who can tell their stories. So, policy can get, very complicated and, somewhat wonky, and there are a lot of statutes and regulatory pieces. But what we bring to the table and why advocacy is so important are those personal stories. And I can tell you that the most powerful speeches on the floors of state legislatures and houses in the Senate and all across the country, in Washington, D.C., inevitably an elected official who's championing a bill starts with a story. And that story is always from one of their constituents.
Mm-hmm.
And so the power of an organization like the American Cancer Society Cancer Action Network is that we do have volunteers from all 435 congressional districts, lead volunteers in all 50 states, Puerto Rico and Guam and Washington, D.C. And that means that we can reach into that volunteer structure and find a constituent. And at the state level, same as you noted. So we follow up. We become a evidence-based resource for elected officials in their offices. But what really swings a vote and makes a really big difference is that story. And that's what elected officials remember when they're trying to decide how they're going to vote. And I will just note, I wrote down because they're really impressive. The biomarker coverage law, which is an insurance mandate, not an easy thing to pass, passed 96-1 in your House and 97-1 in the Senate. And that
Yeah.
is the power of the patient voice. There are not a lot of
Yeah.
things that get that kind of bipartisan support. And we're so proud of our volunteers leaning in and really committing their stories and being willing to share their stories with elected officials. It makes them understand so much more about why their vote is so important.
Yeah, and let me lift up the women that I just mentioned, and we've got wonderful volunteers, but in this case, two women in particular, Gail Orcutt,
Yeah.
a teacher who was never a smoker, because of radon, developed lung cancer, and her lung cancer actually had a ALK mutation for which there was a design targeted therapy. Unfortunately, Gail died before we got the bills across the finish line and got them actually enacted. But she really passed the baton on to Maria Steele, who is still a champion fighting for us. Another woman with stage 4 lung cancer caused by radon. And her cancer cells have a mutation called EGFR, for which there is a targeted therapy that allows Maria with stage 4 cancer to continue to thrive. In fact, she and her husband Pat are going to do a bicycle ride from Canada to Mexico, raising money for the American Cancer Society Cancer Action Network. And two examples of volunteers that have used the wisdom they gained from their own cancer journey to help others on their cancer journey.
Yeah, I love you uplifting those stories because they're so, and the individuals that are willing to share those stories, so critically important. And one of the things that's really been a sea change for me in the time in which I've been doing this work is people talk about breast cancer or they talk about lung cancer, but the reality is there's so many different subtypes of, and I'm not an oncologist, right? So I don't have a clinical background. So many different subtypes of breast cancer, of lung cancer, and the therapies, particularly and precision medicines in particular, precision medicine therapies in particular, they are specific to a mutation. But the only way you know if you have that mutation is if you have a biomarker test. And if there's not insurance coverage, then the person who gets that biomarker test is the person that can afford it. And we know that a lot of people can't afford $500, $1,000, $1,500, whatever that biomarker test ends up being. So one of the things that's really important about insurance coverage, it has become a critical proxy for everyone to have equitable access to innovation that's coming on the market. So what we don't want is disparities growing because all this innovation is coming on the market, but it's not being equitably accessed. And obviously access to care and equitable access to care has been a problem for decades. But for innovation in particular, we're really finding that we need to be out in front of things that are happening, that are coming onto the market, and make sure we've got some reimbursement strategies aligned and that the regulatory agencies are staying on top of that, because we don't want to see some people accessing, the right therapy for their cancer and other people never being able to access that therapy because they weren't able to get through, the process that would have identified their mutation. And you're an oncologist and you can explain this better, but it is something that really resonates with elected officials. They don't want to hear that all this research that has been invested in at the federal level through biopharma is out there, but not everyone is benefiting from it.
Right, right. So it really does bring into the whole part of the solution to reducing the burden of cancer does come down to money, not only the money to invest in research, but then, to be able to have everyone access the scientific breakthroughs that allow them to get the best possible care. I had the pleasure of attending a conference that ACS Can put on earlier this year in Washington, D.C. about the financial toxicity of cancer care. Nowadays, even if someone has really, quote, good insurance provided by an employer, they may well have $10,000 of copays and deductibles. And whereas you and I, if we all of a sudden got cancer and had to pay $10,000 out of pocket to get $300,000 worth of care, we'd come up with that. But many people in the United States, and you probably know the number better than I, don't have $10,000 to pay for the 1 year of copays and deductibles. And in truth, if you're diagnosed with cancer this year, you will have $10,000 out of pocket next year and the next year and the next year. It doesn't take too many surveillance scans to max out your copays and deductibles.
Yeah, I'm really glad you brought up this issue, Dick. And I think that what we're finding is that there are a lot of public policy interventions that can be really impactful from a medical debt standpoint and financial toxicity. Obviously, the best intervention that would be sustainable and the absolute best for patients would be to avoid that debt altogether, making care more affordable, making insurance more affordable, ensuring it's very comprehensive. But the reality is our healthcare system, a big part of the cost of that healthcare system is carried by patients, cancer patients and others. But as Dick, you mentioned, if you've got a serious diagnosis like cancer, it is extraordinarily expensive. And so we did have our National Healthcare Forum, which we do every year in May in Washington, D.C., that focused on that financial toxicity and the data that we have. There's been an incredible amount of data that's shown, or research that's done that has produced the data that shows the financial toxicity. And I mean, even we've shown that even something as small as like $50 for a copay for medication, for example, is a barrier for people. So if you have to have inpatient or some sort of major treatment for your cancer diagnosis, those dollars add up really quickly. And we're seeing more and more opportunities in states to pass laws that, one, ensures that medical debt does not influence your credit rating. So it's, as many people know, you get into these situations where you have debt and it snowballs, and then the next thing leads to the next thing, and then you can't get a car payment. And so if you can't buy a new car, and if you can't get a car, you can't get to work, and then you can't have a job. So, I mean, all of these things are very interconnected from your life. And so we're looking at all sorts of interventions. As I said, we work very hard on affordable healthcare insurance, and that is a critical foundation. But there are lots of other things that we are looking at from a public policy intervention standpoint, laws that can be passed, regulations that we can support that reduce the impact of that debt. We're seeing states that are buying medical debt and releasing patients from that burden. And there's a lot of public policy work that we'll be doing in the coming years around that issue.
So once a year, the ACS-CAN brings to Washington, D.C., a representative from every one of the legislative districts across the country. And we're going to be coming together in September this year. And what are we going to be asking of our legislators when we go up and meet with every senator and member of the House? What's our ask?
So you're seeing me smile big because it's like Christmas. It's one of my favorite times of the year. It's exhausting, as Dr. Deming will attest. It is a multi-day effort, but we are probably one of the only policy organizations that can actually have 535 meetings in one day, because we bring over 700, probably close to 750 volunteers into Washington, D.C. every September. And so we have what are called asks. So these are the specific policy priorities that we are asking members of Congress for this particular, congressional session to support. And we have three asks this year. The first is going to be the largest amount possible for the National Cancer Institute and the National Institutes of Health to ensure that our research pipeline continues to produce those therapies that so many people are waiting for. We have so much good therapies on the market, but there's a lot of research that still needs to be done, and we want to make sure that pipeline stays strong. So the first ask is related to NIH, NCI appropriations, National Cancer Institute appropriations for research, as well as the cancer control programs and the CDC. So that's oh gosh, I'm like having a moment here. Dick,
Center
help me
for
out.
Dis-
Center.
Yeah,
I was
Center
like,
for
I kept wanting to
Disease
start
Control.
with clinical. I'm like, it's not clinical, Lise. And the only thing I can say is it's 7 o'clock, and I'm, long day. But so CDC has an entire oncology arm. And they have really important cancer control programs, and they rely on the federal government to give them money every year. So that's part of our appropriation ask as well. So we have a money ask. The second thing that has been quite exciting, this congressional, we're in the 118th Congress, so we're soon to be in the 119th, but we have been working on a pathway for reimbursement. So a common theme that you heard with biomarker testing coverage at the state level, this is at the federal level, for innovation that is coming to the market is not, well, it's available, but not yet FDA approved, which is multi-cancer early detection testing. And go ahead, Dave.
And I was just going to tell you that we've done several segments of this show on the multi-cancer early detection, so the folks in the room know about this exciting technology. And I just met with another person today over the lunch hour with the different company, but this ability to, in a blood test, detect circulating tumor DNA in a blood test is going to change the way we do screening, and it's going to also change the way we might do follow-up testing. I mean, it may be that this blood test might be better than a PET scan at detecting whether we've got rid of the cancer. So it's exciting technology, and as you said, the reason that the American Cancer Society Cancer Action Network's involved is to make sure that once it has proven to be worthwhile in reducing the burden of cancer, that Medicare would be able to pay for it, because it takes an act of Congress to change Medicare, and that's that's what we're doing, right? Is an act of Congress.
This is why I have a full-time job. Medicare needs an act of Congress in order to be able to cover these tests. And again, these tests are available commercially right now, but they have not yet been FDA approved. And we're really looking for clinical utility, right? Who is it that would benefit the most from what these tests can discover? But I am with you. I'm convinced that this technology will, I've a young adult children, they're in their 20s, and I think that their screening and early detection will be completely different than the screening and early detection that my husband and I have, now follow through guidelines. And so it's a very exciting opportunity, but it is right, as we were talking earlier, if we do not figure out the right reimbursement strategy for this type of innovation, then only part of the population is going to access it. And that creates disparities. And that's something that we never want to see. So that's we have worked really hard. We have over 300 co-sponsors in the House for that bill, nearly over 60 in the Senate. So we have a lot of support. We were able to actually go to the House Ways and Means Committee and get a unanimous vote out of the markup just a couple of months ago. And that was a sight to behold. That is not something that's happening very often, especially right now in Congress, in the cycle that we're in as it relates to the elections. So I'm really, really proud, so proud of our volunteers in that work. And so that's our second ask. And then finally, as I mentioned, there are extended tax credits, which for people who have to buy insurance individually on marketplaces nationwide. So this is, ACA compliant plans that are sold every year through open enrollment. Some of you may actually have your health insurance through marketplace. And so those tax credits are going to expire in 2025. And, insurance sets their rates in the middle of the calendar year so that they're ready for open enrollment in the fall. And so our goal is to make sure that every single elected official in Congress understands how important those tax credits are to keeping healthcare insurance affordable. Millions and millions of people buy their insurance on the marketplaces, and millions benefit from those tax credits. So we'll be letting everyone know that that's something we're going to be working on. There's not an actual bill yet. We're hoping will be in a year-end package. We'll see whether that happens or not post-election.
Okay. Well, good. Well, I'm excited to come to Washington with all
Can't
of
wait
our
to have
other
you.
volunteers and do that. So we've said many times cancer is not a partisan issue. There's not a pro-cancer caucus, and there's not an anti-cancer caucus. But much of what comes down to financing and money, that's where you sometimes get a bit of a political divide that could be, a RD sort of divide. So Lisa, if you had an audience tonight, no, let's not do it tonight. Let's do it next week. You had a half an hour with Donald Trump and a half an hour with Kamala Harris. What questions would you ask them related to cancer public policy? And what would you encourage them to do?
Yeah, I would love to have that time. That would be very exciting, actually. I think I would probably start with asking them about their connection to cancer. And I know both of them absolutely have connections to cancer. And I think that one of the things that we find successful is to tell us about your experience. Do you know someone who has cancer? Does anyone in your family have cancer? What was their experience like? And once we sort of establish that they certainly have a cancer connection, I would then go to why it is so important for elected officials and policymakers to lean into priorities that reduce the cancer burden. And I would probably lean in more towards the economic argument of how much our government spends on the burden of cancer. Cancer is a disease of the aged, and that population is covered by Medicare, which is a government program. And many people are also covered by Medicaid, again, a government program. And so it's important that the country understand the role that the government can play in reducing that cost of cancer and the burden of cancer. And by supporting, our priorities, such as more research money, reducing the cost of cancer for individual patients, ensuring that early detection and prevention is well funded. That's actually ultimately going to save the country money. It will save the Medicare program money. And we have the data to show and prove that. So that's probably the area that I would focus on from an economic lens standpoint. I do know that the vice president's mom actually was a breast cancer researcher, and she actually died of cancer. And so probably lean in as well on how important it is for cancer patients to have support. We've worked on palliative care legislation. And so I would bring up sort of, again, why I think when people, unless someone's talked to them, an elected official may not understand how their role is so important to the fight against cancer. And so I would definitely spend that half hour making sure that both of the presidential candidates understood the power that they have to influence the more than 20 million survivors and those who are going to be diagnosed with cancer next year.
Right. 2 million Americans will be diagnosed with cancer
Over 2 million.
this year. Yeah.
Yeah.
And
nearly
unfortunately.
nearly 20 million survivors. And as you noted, like those survivors have really high engagement with the healthcare system. And look, we know, our healthcare system is really complicated. It's really hard to navigate. So navigation is another area that I think everyone can resonate with. And medical debt, frankly, because that is something that impacts everyone because a cancer diagnosis is so expensive. So I think that we have proven, certainly with, Em said most recently, that there is a way to create a conversation and a dialogue with everyone that can support priorities that we have for ACS CAN and cancer patients. So I think that we're consistently getting better at this, and I'm really proud of the progress that we've made across the country. And there are many states that are very, very conservative. There are states that are liberal, and we are able to show in every single state legislature for the entire time I've been here, 17 years, we've always have a win. We always have something that we've influenced, and it's really because of our bipartisan lens that we're able to do that.
So this is a special
What would you
year.
say if you had that half hour? I want to hear your answer to that question. Such a good one.
All right. Wait. I'm the one asking the question. No, no, the good question. I love the way you answered it, that you would start off by, asking them about their own cancer experience, whether it's themselves or others, and inviting them to share their stories, because just as they put on their pants one leg at a time, they also experience other things in life that you and I and everyone else does, and that is cancer. And so getting that common denominator about what's your cancer experience, what's been the experience of your loved ones, and how could their cancer journey have been better, and what role do you see government playing in helping to reduce the burden of cancer? So I love that. I was trying to think if there'd be something more pointed that I would ask. I know, you know me, I'd want to make friends and
Yeah,
try to
I'm like you.
find a common ground rather than
Yeah.
poke the bear with a stick.
Exactly. And I think that one of the things we've been talking about this actually as we're thinking about, all the new members of Congress that inevitably will be coming in for the 119th. And it's really important to talk to every single member of Congress. It's harder to get to every single state legislator because there aren't quite as many of us, but the volunteers are there. Even walking into an office where you may be talking about something that someone isn't going to support, making sure that they understand why ACS CAN, why the American Cancer Societies, what the evidence has shown, it helps. It really allows people to say, we have great relationships with all of these offices, and it allows them to say, thank you for explaining to us why this is your position. And it takes away from you're supporting this because the Democrats are supporting it, or you're supporting this because the Republicans are supporting it. And so we're able to kind of disarm with our science, right? So we take the science, the evidence, we bring the studies to them, and then we talk about the stories and the way. And we just met with Speaker Johnson in the House a couple weeks ago, and we had a really great meeting. And again, we may not get everything that we want, and depending upon whose office we're walking into and what we're asking for. But I do know that by creating those relationships and having so many volunteers, so the volunteers are going to be in DC, and then the members go back to their home districts and they see them in the grocery store, or they have a town hall and they get reintroduced again, and they work with their staff. And that consistent engagement, it really, really makes a big difference. And we only are able to do that because of our volunteers. Otherwise, we wouldn't be able to get to everyone that we need to get to.
And Lisa, do you recall, did the Speaker of the House, Johnson, share with you his connection with cancer?
Yeah, so I wasn't physically in the meeting, but his father, I believe, died of lung cancer, if I remember correctly. And so, they're powerful experiences. And I really think that when we're able to sort of talk about those experiences with their teams, it makes a very big difference. So I'm really, I'm proud of being able to have those conversations. I often tell the story that we worked on passing at the national level tobacco 21, right? So that you had to be 20, instead of 18, you had to be 21 to buy a tobacco product. And then President of the Senate, McConnell, who has not been a big supporter generally of our work, called our office, had his chief of staff call our office and to say thank you. And so that's, there are so many ways in which we can create goodwill through conversation. And again, yes, do we want everyone to vote exactly the way we want them to vote? Yes. Do we want them to keep all of our issues a priority? Absolutely. And that's not going to happen all the time. But if there's a point where there's a decision to be made and they can hear our voice in the back of their head and say, I want you to find out what ACSCAN thinks about this. I want to know how this would impact cancer. That's the goal. That's the perfect outcome for us.
Yeah. And we're going to go to questions, but I know one other shout out, because it speaks to what we've been saying. So the person who signed the biomarker bill into law is Governor Reynolds, who shared that her husband has stage 4 lung cancer and is on a targeted therapy because they found out through biomarker testing that his cancer has a mutation for which there is a targeted therapy. So that's powerful. So we have some powerful people in the room right now. In fact, as I look around, I think almost everybody in the room here has been to our Iowa lobby days with ACSCAN. So they know about ACSCAN. So we're going to open it up to questions here in the audience. If you are watching us live streaming, there's a comment section that you can fill in your question, and we'll be monitoring that. So let's start off with our in-room advocates. Boone.
Yes, Lisa. As you know, the state of Iowa is number 2 in cancer occurrence. So what are you doing as the president for ACSCAN to help our state with research to find out why we're number 2?
So we're number 2 in terms of incidence.
Yeah. So Dick and I were just having this conversation, and I think that epidemiologic studies are really intensive and really, really important. And one of the things that makes me proud to be part of the American Cancer Society is that we have committed to these studies, which are basically long-term studies, right? So people sign up, we might take their blood, and we're able to track them over time. And then you can go back and look if someone gets a cancer diagnosis, and you have a cohort of people who get a cancer diagnosis and don't. And for those that do, you can go back and look at those surveys over time and the data that's been collected. And so I know that there is incredible interest to do more research in Iowa to really understand is it environmental factors, et cetera, that really will help us to better understand the underlying evidence and science that has resulted in this unenviable ranking of being the second highest state for cancer incidence based upon your population. So, I know that there's some conversations going on with one of my executive team colleagues, Dr. Bill Dayhut, his team, Dr. Alpa Patel, who runs a lot of these studies. And, be hopeful that we can figure out a way to get some of this work done so that we can better understand. I would say an emerging issue, and I think most of you have probably seen the trends that younger and younger people their incidence of cancer are increasing. And I just think generally the topic areas of cancer in the environment continue to be of interest and concern. And I don't know, you've got a very agriculture heavy state, and it would be interesting to see what the scientists can really understand and find out.
Yeah, we have a ag heavy, but we also have a radon heavy, where we
Yes.
probably have the highest concentration of radon under Iowa than any other state. So some of us are kind of wondering whether we know radon contributes to lung cancer, but you know, as someone who studied radiobiology, it wouldn't surprise me to find that maybe radon might also be contributing to some of our high incidence.
Yeah.
We have another question, Angelina.
Well, yeah, it's kind of swaying into the radon part. We were at the state fair, and there was a booth there offering to do radon testing.
Mhm.
And so I filled it out, and he goes, "Do you understand about radon?" And I go, "Yeah, I dealt with breast cancer." And so we're going to have this house that we're in tested. Bit nervous, but yeah, I mean, definitely, yeah, want to be on the safe side. Because then I think when you buy a house, you're under the assumption, oh, we bought the house, I'm sure they tested, and it's not always the case. And does it even matter? Even the how long that house is there? It's basically what's on the ground, right? If I'm understanding right, what's on the soil with radon.
I'm gonna phone a friend and ask my good friend Dick to
Yeah.
talk about radon. I mean, but it's a great example. Let me just say that this is, again, like, if whatever is the right mitigation strategies for radon, you have to pass a law, right? Because it's just voluntary mitigation. It's just not going to happen, right?
Mhm.
And so this is why public policy, it's a perfect example of why public policy is so important. And then, as you learn more, you may have to change the law, right? So I don't, my guess is that there's still plenty of research that's going on the effects of radon. As it relates to, cancer incidence. And as we learn more, you have to do more. But I don't know a lot about sort of the levels of radon and, if your house is being tested, kind of how you do that mitigation in a way. I know there are laws, and I live in Maryland, and I know we had to have a radon test. And those results had to be disclosed as part of the purchase of our home 20 years ago. So, but I'm not sure what that really means at this point.
Yep. And you might have noticed that Angelina mentioned she did this at the state fair. So the Iowa State Fair, which is the best state fair in the country, just ended on Sunday. So far, we have decided not to do a study to see if corn dogs cause cancer. So,
you get run off the run out of the state fair.
We haven't done that study yet.
Yeah.
Hey, George, you have a question.
Just a quick question about Medicare for All. We used to hear a lot about it in Congress, in the general body. Then we heard about it only amongst the most progressive squad members, as they're called. And now we don't hear about it at all. Do you hear any talk on the Hill? Is Medicare for All dead, or can that be resurrected? What's the status of that?
I think it's not a viable policy approach, at least for the upcoming 119th. I think that there's the stakeholders just throughout the medical ecosystem make that type of a change really, really hard to pass. And so I think that the strategy, at least I see, certainly the Harris-Waltz campaign moving more towards closing gaps and making existing structures better for patients, as opposed to a wholesale change of the insurance system. So I agree with you that it was a much bigger conversation in the past, and I just don't think that there's political viability. And so the question then is, with the existing system, how do you make it better? One of our major priorities for ACS CAN is to make sure that all 50 states have expanded Medicaid. Iowa has expanded Medicaid. You guys are up for renewal in 2025. That does not have to be a legislative effort, but they've got to, continue that expansion through a Medicaid waiver. And so I think our goals need to be to close the gaps as it relates to insurance coverage. We're not going to get sort of a wholesale change of the way in which people get their insurance in the United States. Then we have to make sure that every single gap of population that's closed. But I think just political viability, that's one of the reasons why it's not being talked about anymore. There's no way to make it happen.
Okay. Ron?
Concerning one of the asks that you have coming up in this year about the blood work and trying to get Medicare to pay for that, I know it's kind of a general question, but is that what's the expense of that blood test? I mean, blood test sounds like, hey, that's easy.
It's a great question, and it's really important. So the way in which we've structured so there are two steps to this process, and this is not a mandated coverage. So all this says is that if there is an MCED test, any kind of blood test, and the definition's fairly broad, that gets FDA approval, then Medicare has a statutory authority to look at a coverage decision. It's called a national coverage decision. That may be a regional coverage decision, but a national coverage decision, NCD. And that's when Medicare, you read about this stuff, most recently, the biggest headlines were around an Alzheimer's drug, right? So the drug got FDA approval, and Medicare went through a process to determine whether they were going to reimburse that medication or not. And so they will go through a national coverage decision if a test is FDA approved, and they may say only this population, right? Screening often, you don't screen everybody because the utility of that doesn't make sense. So for certain, screening, you would only screen someone 65 to 75, for example. I'm making that up. So the current cost of the bill over a 10-year time period, which is the time period in which you have to determine a score of a piece of legislation you're trying to pass, is we haven't got the final cost, but it's about $4.4 billion. So, and one of the ways in which we've kept that cost down, even though it sounds very expensive, it's, the Medicare program itself is very, very expensive. It's a small percentage, is by phasing in the age of people that would be able to access the test if it's, proven to be clinically, the clinical utility has been proven, and that the coverage decision aligns with that clinical utility. So that we're waiting, but we worked really hard to make sure that this coverage, or this pathway for reimbursement, could be affordable for the Medicare program. And that is, again, we know that there won't be an FDA approved test for at least a few years. So that means we have a couple of years of zero score, we call it. And then they phase in age groups after that. And so it just allows the CBO, which is the one who scores these bills, to sort of look at the underlying population that may benefit or may have access to it, and then they cost it out. So the initial cost was like multiple $50-60 billion. And so we've worked really hard to, obviously that number was a little facetious, but we worked hard to bring that number down. It's a great question.
I'm going to answer Ron's question a little bit more personal at an individual level. So one test doesn't cost $4 billion.
No, it does not. That's Medicare cost of the program.
You didn't say
over
that.
10 years.
But to bring it down, so a couple of things. One is, President Lacasse has mentioned many times, MCED. So first of all, for those who aren't wonks and who don't live this, the MCED MCED stands for multi-cancer early detection. So that's what that acronym is. It's not quite on the tip of everybody's tongue. So it's a multi-cancer early detection test. So right now, when we screen for cancer, we have 5 cancers for which we have validated screening tests. And you probably could think of all 5 of them. So breast cancer, mammography, colon cancer, colonoscopy or stool-based testing, lung cancer, a CT scan, prostate cancer, a PSA blood test, and cervix cancer, which is a pap smear. So those are the 5 cancers that we have validated screening tests for. This multi-cancer early detection screening test can, with one tube of blood, test for 50 different cancers. And also the exciting part is that they are the 50 most, most virulent or most aggressive cancers. So these early detection blood tests aren't very effective at testing low-level, indolent, non-aggressive cancers. So the answer to what you might have been asking is, how much does one blood test cost for one person? The answer is $949. But right now it's being recommended by the company that you don't do it instead of the 5 other proven tests, but you do it in addition to. So that's the answer to, as of today in 2024, if you wanted to do the test, how much would it cost? You can get the test done. Insurance won't pay for it. It would cost you $949. 2% of people who get the test done will have a positive test. And I just gave way too long of an answer. Lisa, I have just used up all your time.
I love listening to you. That was great.
So President Lisa Lacasse, president of the American Cancer Society Cancer Action Network, has been our guest. Thank you so much for being our guest tonight. If anyone watching this program tonight knows someone that would benefit by watching it, it will be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and the Mercy Cancer Center website. I hope you'll join us again next week for our cancer education series. Thanks, everyone.